refers trifocal IOLs, and Dr. Nidhi will give information about unsatisfied EDOF patient, whether there are such cases of unsatisfied EDOF patients and how to take care of those issues. And followed by there will be a very interactive session on different cases and which are the cases where you want to go for a EDOF or trifocal or monofocal. So we'll discuss on that. So myself, Dr. Sourabh Patwardhan, I'll be starting with my first topic, that is optical principles of EDOF. You can start the timer also. Okay. So this is a small question for audience. I think we have few. So you can just try to answer this. This is a very trick question. So what is the distance between the foci inside the eye if the near eye is +3 diopters? Okay, the hint is that every 1 diopter is equal to 0.3 mm. So can any of you answer this question? The distance between foci inside the eye if the near eye is +3 diopters. You can try to answer. Yes, sir? Okay, so this is a trick question because the answer is 0. Okay, because when we see different foci of any multifocal, trifocal on a optical ray diagram, they show different foci. But what is happening inside the eye is that all the foci are basically on the retina. That's when the patient can see clearly. So this is how the multifocality works. Okay, you can see this picture. This is again an illusion picture where you can see the big faces. At the same time, there are small figures which are seen in the picture. Now, when you look at this picture, when you are looking at those small figures, okay, you know that the bigger face is also there in the picture, right? But your brain can only focus on one thing at a time. It will shift between the small figures and the bigger face, okay? So the brain knows that the other image exists, but it will focus only on one image at a time. So that's how the multifocality works. So even if there are multiple images from different distances, the brain decides on which part of that image to focus on. So by definition, EDOF has single elongated focus. Okay, so it doesn't have multiple foci like trifocals or multifocals. What is the best part of EDOF? Why EDOFs came into market was because of minimum light loss. So why we are using more EDOFs in certain patients is because there is minimum light loss, and that means the contrast sensitivity will be higher than when you are using trifocals or multifocals. Okay, so why does this trifocal have different issues with them? So what is the cause for the glares that patient experience? The glares are caused by the sharp transition of the element. So when you have these rings, every sharp transition, there will be aberrated rays going towards the retina, and that is what causes the glares. While whenever there are multiple diffractive or refractive elements, they create more images inside the retina, and that is the reason for the halos. So more the rings, more will be the halos, more the transition, more will be the glare. So that is how it will be seen, and that is what is seen in the optical bench testing also of the trifocal IOLs. So these are the common aberrations we see with the trifocals. Now what happens in a EDOF is that there are smoother transitions, so the glares are significantly reduced. The rings are usually limited as compared to trifocal, so there might be halos, but they are less. Okay, so that is how we typically see in case of a extended depth of focus IOL. So this is same which is seen in optical bench testing. I will not go through different details. You can see the upper one is trifocal, the lower one is a extended depth of focus IOL, which has less glares and halos. Now we'll come to main important part where you have to understand optics of different IOLs. So when we categorize the EDOFs, they are categorized into these 6 types. Okay. The first type is monofocal EDOF, and now this is where the confusion starts. Monofocal EDOF is actually the true EDOF. Okay, what do you mean by true EDOF? There is a single elongated focus only in this monofocal EDOF, which is based only on single spherical aberration. So we have highly spherically aberrated IOLs. The examples are Ihance, Magnificent, Isopure, Rainer EMP, and many more. The drawback of all these IOLs is that when we have high spherical aberration in the IOL, you cannot elongate the focus more than 1.25 diopters. So if you consider true EDOF, it can never give you a addition of more than 1.25 diopter without losing contrast. Okay, so we generally, for our use, we categorize them as enhanced monofocal rather than EDOF, because by definition, EDOF should have at least 1.5 diopter of elongated depth of focus, which is not provided by these IOLs. Second common, the category which was initially launched was the diffractive EDOF. You know about Symphony and 80 Lara. These were the first EDOFs which were introduced in the market. But again, they had same rings. So though the overall contrast was better, there were still patients who complained of glares and halos. Third category is the newer category of EDOF, which is called aberrational EDOF. So it's similar to monofocal EDOF, but instead of using only single spherical aberration, there will be combination of plus and minus spherical aberration. So it will be a kind of undulating aberrations on the profile. So you will not be able to see any rings or any transition zones, but there are multiple aberrations which are added. The example is Minivel. Pinhole EDOF is still not launched in India, so we'll not talk about it, but again, it's based on the pinhole principle. Polyfocal, again, we don't have any in India. And the last category is the refractive EDOF. I think most of the IOLs are now based on this technology. The upper one is VVT and lower one is Lucidis. Again, I will highlight on the exact optical profile of each of them. I call this type 1 refractive EDOF because you can see these are radially symmetrical EDOF. So right from center to the periphery, the transitions are uniform all 360 degree. But there is a category called asymmetric, radially asymmetric or segmental EDOF, where there will be segments. One part is for near, the second part is for the distance, and there might be an intermediate zone. The example is Lentis Comfort or Lentis M plus X, and their similar versions like autofocus. So these are radially asymmetric. So now all these categories might be little confusing. So to for my understanding, I divided all the EDOFs into these three categories, and I will explain the clinical significance of each. So first category, I call it center near EDOF. Okay. So by center near EDOF, I mean is that the central 1 millimeter zone is for the near or intermediate vision. Okay. That means the predominantly it is for near vision. So example is like Lucidis or InFocus and other. Second category is center distance EDOF, where the central 1 millimeter zone or slightly larger zone, say 1.2 millimeter, is dedicated for the distance vision. Okay, so this is predominantly distance EDOF. And third one is the segmental EDOF, as I said, which is radially asymmetric. So part is for the near and half part is for the distance. So this classification is very useful when we are considering using a EDOF for a particular patient. Just to give an example, you get a patient who is more interested in the distance correction. That means he wants distance vision to be crisp. You will maybe go for a center distance EDOF rather than center near EDOF. While on the other hand, patient wants more of near or intermediate vision, distance can be little bit compromised. In that case, we can go for a center near EDOF because we know that irrespective of the pupil size, patient will definitely get near vision better than the other. And segmental EDOF is basically combination of two, but the advantage is that the pupil dependency is the least in case of segmental EDOF because you are cutting the pupil into half. So even if you have slightly smaller pupil or larger pupil, it may be more pupillar independent according to my experience. Okay, so just one last question before I end this topic. Okay, so you can answer this if you have heard my talk correctly. How many foci does a true EDOF IOL have? Please attempt this answer. One of the options are 2, 3, no true foci, or more than 3 foci. It's a trick question again. Yes? Yeah, so there is no true focus, or other way I would say it has infinite number of foci in a particular region. Okay, so that is when we describe a true EDOF. So if you find in my presentation, I have defined what is a true EDOF, and most of the EDOFs that nowadays we are using, where they are categorized as EDOF, are either most often are refractive EDOFs. So they will have a refractive element added in the optic. That's why when we check the depth of focus curve, patient will not have continuously clear vision all throughout. There will be little dips in between. For example, with -1, patient may have good vision, but again at -1.5, there might be some dip, and again -2, it might increase. So that means there is a refractive element added over the extended depth of focus. Okay, so that is about the basic of the optics of the EDOF. Next, I think I would like to invite US or Amit will take. Okay, so I would like to invite Dr. Nitin Deshpande. He's a prolific cataract, glaucoma surgeon and refractive surgeon from Thane, and he has vast experience of using different types of EDOF, so he will be sharing his personal experience about the same.
Yeah, so thank you, Saurabh, and I'll be speaking about 6 different EDOF lenses that I have done over some time now. And these are the lenses: LuxSmart from Bosch & Lomb, Alcon VVT, Rayner EMV, Acryl Isert from Biotech, Lentis Comfort, and Minivel. Saurabh has already described principles of these lenses. I have followed the classification given by a meta-analysis published in APAO. That is, these 4, LuxSmart, Rayner, VVT, and Acryl Isert are classified as type 5, that is modified central optical profile lenses. Minivel is type 1, that is a pure EDOF based on spherical aberrations, and Comfort as type 3, that is the multifocal with low power near vision addition. Now demographics, the male-female ratio was equal, and mostly elderly population. Almost 70% underwent phacoemulsification, 27% with flax, and others 1.6 had a combined glaucoma surgery along with implantation of a EDOF lens, and 9% had glaucoma, and 5% had some retinal pathology like mild to moderate retinopathy, and some clinically significant macular edema partially, but we found them to have a good vision potential, so we implanted these lenses. Now only select lenses had a cylindrical option available, so Rayner EMV and VVT are the only ones available, and Minivel. So these 3 are available with toric model. So you can see in baseline these 3 groups had some cylindrical correction, patients with cylindrical correction, but if you see 1 month and 3 month outcome, the cylinder was corrected beautifully by all the lenses. The refraction again variable, but if you see 1 month and 3 month outcome, the refractive outcome was excellent in all the groups. The ad on the first month was again variable. However, Acryl Isert had a little higher ad compared to other lenses, while LuxSmart, VVT, and Minivel had the least. And as we go ahead, as I share my statistics, you'll know that these 3 lenses have done exceptionally well. At 3 months, number of patients were laser in this group. However, the ad increased in some of the groups because some patient demanded a better near vision, so we gave them little higher ad at the end of 3 months. But the number of patients in 1 month group were much higher than 3 month group. Those who were really happy, not all of them followed up. So if you take uncorrected intermediate visual acuity, LuxSmart, VVT, and especially Minivel stands out above other lenses. However, Rayner EMV, Acryl Isert, and Comfort also gave a decent amount of uncorrected intermediate vision. At the end of 3 months, again, if you see LuxSmart, VVT, and Minivel have done exceptionally well, although Acryl Isert and Lentis Comfort also have given reasonably good result. Uncorrected near visual acuity, Minivel stands out here, having the best uncorrected near visual acuity. However, patients in other groups are quite happy. However, Lentis Comfort and Acryl Isert gave a little lesser near vision acuity compared to other groups. And at again 3 months, the similar picture for near visual acuity. Again, as I said, these patients, the number n number in this group was lesser compared to 1 month, And these are the patients who demanded higher addition in some cases, and we had to give them that higher addition to make them happy. But overall patient satisfaction in all with all these lenses is quite good. Contrast in all the groups is excellent. None of the patients complained about any contrast related issues. Just representative defocus curves. This is LuxSmart. You can see how beautiful VVT defocus curve is. This is Rayner, Icryl Cert, and Lentis Comfort. Especially when we do Rayner EMV, we do a micro monovision where one eye we correct fully and the non-dominant eye we correct slight target little minus 0.5. And with that, this near and intermediate vision improves a lot, even in Rayner EMV cases. And this is Minivel. If you see Presque satisfaction survey, most of the patients were very happy with all the types of lenses. If you see Minivel was exceptionally good in this regard. Most of the patients were free of near vision glasses. So thank you. See, you have to see the picture as a whole, not in pieces. So this is a multifocal lens gives you story in pieces, while EDOF gives you a continuous story. So if it was a continuous story, you would have come to know what I was doing. But here you see only that. So I was trying to jump and capture that. But since this is not a video, it just captures it by bit and pieces. So that is why EDOFs are good, because they give you that continuous vision for near. Thank you.
Thank you, Dr. Nitin. And just one or two questions as Dr. Amit is preparing his presentation. So in your cases, did you target emetropia for all IOLs, or you were targeting little myopia? What was the general?
So all the lenses I did emetropia except Rayner EMV. Rayner EMV works really when you do micro mono. That dominant, although we check dominance and non-dominance in all the patients, but especially in case of Rayner EMV, we do a micro mono.
And one more question is about the distance vision. Though of course we talk about the uncorrected distance and near vision, but what was your personal experience regarding the dysphotopsias or the complaints that patients faced after using these IOLs?
So the beauty of EDOFs is dysphotopsia are almost non-existing in all the lenses. If you see acrylysate model, there are some refractive elements on the surface which you feel that might give patients some halos glares, but even those patients are very happy. So in all 6 lenses, there was no complaints of halos glares. Patients were very happy.
And was there any complaint of ghosting of letters, or when they read, was there any complaint?
I have used some other lenses which did complain of ghosting, but these are the lenses that I do routinely, and these lenses are doing extremely well. So.
Is there any period of neuroadaptation that you feel in certain patients? I'm not saying about 100 patients, but maybe few patients. Do they, because in trifocals we talk a lot about neuroadaptation and taking time. So do you find similar experience, or percentage wise is there any difference?
These lenses behave almost like monofocals, so there is no adaptation period. There are a category of lenses called hybrid EDOFs, where like Triumph or which is a combination of diffractive plus those patients you might have to counsel that there might be some period of adaptation, but the lenses that I have selected, these lenses have no adaptation period.
Thank you. We'll of course trouble you more with more questions later. So over to Dr. Amit Mahajan, another prolific surgeon from Chalisgaon, and he has done some interesting studies on objective parameters like abrometry after using the extended depth of focus IOLs. So over to Amit.
Hello, good morning everyone. Presentation. Thanks Dr. Sourabh for making me part of this interactive IC. So long back, Sir Duke Elder stated that the human eye is one of the most complex yet imperfect optical system. So the basic question is why we need abrometry. One more new machine, like so many graphs, so many representation, why we require this? The answer is very simple. If some of our post-operative patients who is unsatisfied, he comes to us, it is the only way where we can objectively analyze what exactly went wrong. Whether it is a cornea, whether it is a lens or whole of the eye, we can optically check what exactly went wrong. So as you all know, the image formation is degraded only by scattering, diffraction and optical aberrations. So I won't go into the details of the optical aberrations, but let me tell you very frankly that up to only second and third order aberrations which are corrected or which could be corrected optically. Rest of the aberrations, they are taken care by the intelligence only. So what is very special about this eye tracy? It fires 4 near infrared laser beams sequentially, not simultaneously, sequentially, one after another. And each beam contains 64 spots. So total 256 of the spots, they are fired separately and analyzed separately, and that gives us the whole idea about what exactly is going inside the eye. But before testing the results, we must remember that these wavefront aberrations, they are pupil size dependent. Pupil center and location may change in mesopic, photopic and pharmacologically dilated condition. So here the gold standard is to perform the eye trace with a natural neutral pupillary dilatation in mesopic light condition. So what are the parameters or what are the tests we look for in any EDOF or any lens conditions? So we'll go one by one. So the first and the most important is the Chang's analysis. This analysis is devised by Chang, and as you can see, this is the total aberration. This central square, it shows the total aberration. These are aberrations caused by the cornea, and when you subtract cornea from the total, you get the internal aberrations. Internal means those are the aberrations which we are getting from the IOL. So below is the axial map also. So in this, we get not only aberrations from the cornea, but lens, and here are the total aberrations of the eye we get in the Chang's analysis. And at the same time, this Chang's analysis is very much of preoperative importance. Why it is a preoperative importance? The first thing and the most important thing, it gives you a multi-zone refraction. I think this is the only autorefractometer which gives us multi-zone refractometer. As you can see here, we are getting refraction at 2 mm, 3 mm, 5 mm and 6.5 mm also. And it is also a color coded. Anything that comes in the red color, it clearly indicates that it could not be corrected optically, so it has to be corrected surgically. Here they are showing the total higher order aberrations, total. And in the bottom they are showing angle alpha. Angle alpha is more important in cases of these premium lenses. So we are getting corneal aberrations. So as you can see, there are so many corneal aberrations are present. This patient could not be a probable fit or probable candidate for the multifocal or any premium lens. But at the same time, if you can see, the pupil size is 6.5 mm. So I would recommend that to recheck this patient again and 3 mm, because as the pupillary size increases, the aberrations may increase. So it is of a great preoperative evaluation tool. So this is a post-operative case of Chang's analysis of a lens comfort. As you can see, very minimal internal aberrations, very minimum from IOL surface, that gives a totally very less or very minimum total aberrations. So this is a satisfied patient of lens comfort. But this doesn't mean that multifocal patients have so many aberrations. This is a happy multifocal patient. This is also even not a trifocal case. This is a bifocal case. And as you can see, there are very minimal aberrations induced by this bifocal also. Now, as we all know that checking contrast is not only tedious for ourselves, but tedious for patient also. And we don't have that vector analysis chart or Pelly-Robson chart. So here, this MTF, that is modular transformation function, is only a 1 minute job in which we can get a fairly good idea about the contrast of the patient. So as you can see, again, there are 3 components. This is total contrast, contrast of the total eye. This is the contrast of the cornea, and when you subtract this, we get this contrast which are generated from the lens. So let us quickly see. So in this x-axis, they are plotting the spatial frequencies like 5 cycles per degree or 10 cycles per degree, and on this y-axis, they are plotting the percentage of the contrast. So they have plotted this red box, that is 40% of the contrast at 10 cycle. So anything that is above this red box is considered to be having a good contrast. And again, this is a contrast of lucidis. You can see cornea excellent, lens also very good, fairly good. So total contrast is almost around 70 to 80%. See, this total contrast 5 degree cycle 0.7, total contrast at 10 degree 0.5, patient is doing fairly good. Here I am trying to show you some of the contrast of the unhappy patients. As you can clearly see that Corneal contrast is absolutely very good, but the contrast generating from the lens is not that good. So totally, the contrast of the total eye, whole eye, is in red box, and that is in a danger zone. So here the patients are not happy. So again, this is a dysfunctional lens index. It's objective method to describe the role of the lens. So in another way, it describes the cataract. So this is a preoperative case. This is lens, this is cornea, this is lens. This is cataractous lens. In the below, it is showing the lenticular opacity map. You can clearly see the opacities. This DLI is 1.95, so the total image patient getting is like this. So this is again a great informative tool for the patient. And now the same patient, after the getting post-operative vision, is getting like this. So when we come to another parameter, that is a point spread function, it will show that how a point source of light will exactly look like on the retina. And the ideal PSF will be like a sharp point or sharp focus. They measure it in a Strehal ratio, and the Strehal ratio of 1 is considered to be the ideal one. Again, this is internal, generating from the lens, from cornea, and this is from the total. So as you can see, this is a very interesting case. See, the internal PSF that is generating from the lens is very good, but slightly blurred from the cornea. So total PSF that we are getting is slightly blurred. Now, here you can see how unsatisfied PSF looks like. You clearly see this type of the diffuse image with a Strehal ratio of 0.01. Ideal is 1, and here we are getting 0.01. So how could this patient will be happy? This is an unhappy patient. Then one more parameter is a defocus curve. If we plot the defocus curve or depth of focus curve of both the eyes, we could come to know how continuous range of the vision of the patient is. Here, as you can see, the depth of the focus is 1.1, and that is fairly good enough. As you all know that whenever we are coming to the premium lenses, the importance of angle alpha is we cannot be debate on it. So it is the angle between the visual axis and pupillary center, and that should be less than 0.5. So here, in this chart, they will show you how exactly your optical system is aligned. So you get exact value of the angle alpha also. So to conclude, this is a wonderful tool to know how your toric is working, how your toric is actually performing. You have implanted toric. Suppose you have implanted it on a 10-degree axis, and a patient come to follow up. This is the excellent tool to know exactly where your toric is situated. See, in this top, it is the internal, that is the lens, and this is the cornea, and it has to be neutralized in this thing. So in a corneal map, they are showing that your toric is situated at exactly at 169 degree, and in this they are showing that there is 7 degree of the rotation. So does it going to make any difference? No. Even if you rotate it by 7 degree, they are showing that the ultimate target that will change by only 0.05. So we don't have to rotate anything. And as I told you that anything in the green is okay, acceptable, that can be corrected. So it is again a great tool to check the toricity. Now to conclude, these are few of the lenses which I tried on the 2 parameters. One is a MTF, that is contrast, and another is a Strehal ratio. And as Dr. Sourabh said that what I found with increased add in the EDOFs, like those EDOF, for example, Lucidis or Autofocus Pro, those EDOFs which are having higher central add, like 3.25 or 2.75, they show dramatically less contrast, and at the same time, their Strehal ratio is also more, means not near to the 1. But at the same time, this doesn't mean that all the multifocals they are showing something big, because in this study also, this is Zeiss 809 MP is a purely bifocal, and Panoptics is trifocal. So Panoptics, bifocal, trifocal, they are also showing equally comparable good contrast and Strehal ratio. Just to conclude, these are the values. This is a flow chart, but I will skip it. No lens technology is a perfect replacement for the natural crystalline lens, and more aberrations are induced by this glass than any other in the universe. Thank you.
Okay, thank you, Amit. And before Dr. Sean starts his presentation, just 1 or 2 questions. You talked about unsatisfied patient where you, on the aberrometry, you showed the point spread function and MTF
Yes.
was quite down. So what was the reason for that particular profile in that particular patient? Can you elaborate on that?
Yes, those patients, they were not happy about their distance vision, first thing. Now, the chief complaint of those patients, they are seeing that I am seeing some ghost images like photopsia or like that. And in second thing, they are not happy at all during dim light. Mesopic conditions, they were not happy at all. And in those cases, I have implanted EDOF lenses having slightly higher ads.
Yes.
So,
So I think the take-home message from your presentation is that you cannot deceive physics. That's what, most
Yes.
of the scientists say, though doctors tend to not believe on that. So whenever you have near addition which is higher than 1.5 in the optical profile, just remember that it is going to reduce the contrast for the patient. Now most of the patients will be still happy because we have other retinal adaptations and brain adapts to that. But remember, whenever you are going for any IL, whether it is a EDOF or it's a trifocal which has higher addition, you may have some patients who are not happy with the results. And like this, abrometry might pick up those cases where it's
correct.
So
And for those patients,
yes, Nitin will.
for those patients in another eye, I have implanted different EDOF having lesser ad.
Okay.
And bilaterally, they are happy.
happy.
But whenever they check one by one, they are not happy with the older lens. So,
Nitin, you want to have?
So just one simple point that it is very, let me emphasize importance of doing tear film analysis in all these patients, especially when you're doing EDOFs or because what he showed that it was aberrated, poor point spread function, poor MTF. If your tear film is bad, even after you do a great surgery, all these parameters will be really abnormal. So whenever you do these lenses, make sure your tear film is healthy. If it's bad, you take your time, make it better, and then do these lenses because tear film by itself can induce all kinds of altered point spread function, MTF, everything.
Thanks.
yes.
We'll move on to Dr. Sean, who will be speaking. Dr. Sean Chinchole is another prolific surgeon from Buldhana, Maharashtra, and he has a lot of experience in trifocals because as we know, when EDOFs were launched, they were very high priced and most of our patients were not affording. So which are the patients where he still chooses trifocals over the range of EDOFs that we have? So over to Dr. Sean.
Good morning, everyone. Thank you, Saurabh, for being for this me as this IC. How to choose between trifocal and EDOF? The simple choice is based on your needs. That is advanced, monofocal, and bifocal or trifocal. My experience depend because I am from a rural area, so I know how to keep my patients happy. So happy and satisfied patient. Happy patients are those who no longer desire to wear glasses, housewives, elderly and retired patients. Unhappy patients, young patients, these are always demanding. Teachers, as you know, they always ask so many questions, and even you answer all questions, you did everything very well, still they are not satisfied. So this is another thing is Googlers. They take care of everything with the Google. When they come to your OPD, they have already been searched for everything, and first when you press the button, what is the best lens, the Google shows that multifocal lens is the best. So this is what the Googlers having this problem. Drivers, especially in night driving, not accepting the facts. Patient with higher expectations, patient not willing to operate other eye, as Amit said, because if you will operate another eye, then only the patient will be satisfied. The refractory surprises are always there, additional +1 or -1 diopter. Even after counseling the patient, demand for near vision. This happens so many times. As says, neuroadaptation take longer period. Patient dissatisfaction is directly proportional to preoperative expectations of patient and the cost he paid. Rule of counseling for trifocal is total independence from glasses may not be achieved. This is the first point. Good light is required for reading. Glare can be expected at the time of night driving. Neuroadaptation may take 2 more months. Binocular surgery is preferable as it helps for neuroadaptation also. Patient selection criteria for EDOF. As patient post-cataract surgery individual wishing to maintain an active lifestyle. These are the pictures which I have shown. These patients who demands for great freedom from glasses, good functional vision for performing daily tasks, low level of visual side effects for more comfort at night, and precise astigmatism correction. What to communicate to patient? It is very important to clearly communicate to patient EDOF is not a presbyopic correction refractive IL. It is an advanced monofocal which will give uncompromised distance vision along with good intermediate range of vision. And this is the final take-off message for EDOF. EDOF are performed over multifocal, trifocal in eyes with maculopathy, irregular corneas or glaucoma. Proper patient counseling and understanding patient need is important as it's setting realistic expectations. It will be easier for prudent ophthalmologists to propose an EDOF to their patients. Trifocals and EDOFs are not interchangeable. These are more important. This is my point. When EDOFs are available, but my choice for trifocal for these patients, patient motivated to reduce dependency from glasses, presbyopic patient without cataract, hypermetropic patients are easier to please as compared to slight myopic, bilateral implantation candidates, patient ready to have second eye operation as early as possible, and affordability of patient. Thank you very much.
Thank you, Dr. Sean. And as Dr. Nidhi prepares the presentation, just one question. So, is there any particular situations where you might get confused that this patient is good for EDOF as well as trifocal? In that case, if we just not think of the the financial part, what is your choice? That patient is eligible for any of the implants.
EDOF will be the best. If depends like what patient's demands are there. Like if he's young patient, if he wants to drive, and so many things are there. But if patient don't want to driving and normal, so I will prefer trifocal also.
Trifocals as
Yes.
preferred. Okay. Thank you, Dr. Sean. So over to Dr. Nidhi. Dr. Nidhi Patwardhan is consultant at Nandadi Pai Hospital, Sangli, and she will be speaking about few unsatisfied patients after EDOF implantation.
Thank you, Dr. Sourabh. So you have done the perfect surgery according to you, but the patient is unhappy. So let us investigate it. Lots of points have been covered already, so I'll be covering them fast. As we know, the surgery of the multifocal and EDOF starts before the surgery, the main preparation. So the most important thing is the counseling, and counseling. So whether you are taking into consideration the patient's occupation, his visual needs, his hobbies, and his expectations from the surgery and the IOL, this is the most important point. For example, if the patient wants to do daily night driving and you are recommending EDOF lens, then the patient might not be happy. Or if the patient demands that he wants to have daily extensive near reading without any glasses, and still you are not clear and giving a EDOF lens without any preparation, then the patient might be standing on your head. Then the possibility of glares and halos, if it is explained early to the patient, it has been shown that the patients are more accepting. And of course, this is important that if there is any organic pathology, it has to be tested before, because any pathology which is found out before the surgery, it is a patient problem. But if it is found out later and you tell the patient that you have a thin ERM and therefore the quality of your distance vision is less, then it becomes your problem. Now, regarding the neuroadaptation, in some patients still there may be some neuroadaptation, especially with the complaints of night vision disturbances and some adaptability to do near vision tasks. So if you explain to the patient beforehand, it has been found in studies also that these patients have a better acceptability of the EDOF lenses. And multiple studies have shown that although the intensity of glares and halos in EDOF lenses are less, but still they are present. Then the surgical factors. But was the surgery actually uneventful? We might be able to get away with some surgical mistakes in monofocal lenses, but you need to have a clear cornea with no inflammation and a quiet eye. Ensure that the lens is properly in the bag, no haptic is out of the bag, and if there is a toric lens, that it is properly in the axis. Now the post-op factors, the there are two main factors, the residual astigmatism and the residual error, and the dry eye. If there is any dry eye, it needs to be corrected and treated. Most important factor which has been found in multiple studies is the residual refractive error and astigmatism. It is the most common reason which affects everything, both the near, intermediate and the distance night vision. If it is a high refractive error because of bad biometry, then sometimes very rarely IOL exchange might also be needed. And you might give an option to the patient for post-op astigmatism for LASIK or PRK. In case of a toric IOL, if there is a residual cylinder, it is better to investigate early and do the intervention. In some cases, there might be early PCO or a post-surgical CME, so it is better that you investigate fully and examine the patient clearly without having any preconceived notions. Still, if you find that after following all these steps, none of these issues is present, it is still better that you listen to the patient with an open mind. Sometimes they just want to get you to listen. And always any surgeon who implants a premium lens should always be confident in exchanging or removing the lens. If nothing, it gives the patient confidence in the surgeon that if anything happens, the lens can be exchanged. Thank you.
Thank you, Dr. Nidhi. So I would like to ask the panelists about unsatisfied patients. So if you have any particular experience to share, and also if any of you have done IOL exchange for unsatisfied EDOF patients so far. Nitin?
The journey with EDOF has been quite satisfactory, and I really hardly have any unsatisfied patients. One case I just remember is many times when patient has monofocal in first eye, I do give option of EDOF for the other eye, and most of these lenses work really well in combination with a monofocal in one eye. One of the patients I implanted a central near dominant lens with a central near dominant zone, and patient was complaining of ghosting in that eye. But eventually he settled down, but you know, these things can happen, and counseling is very important. You have to tell the patient that it's when patient tries to see binocularly, compare eyes, then they sometimes fall in trouble. So this was the only patient that I experienced, and you have to be a little careful with these lenses with a central bump. If it is a very prominent bump with a refractive component, then you have to counsel the patients well. But whatever lenses I have shared, 6 lenses, all of those are doing extremely well. And some of the patients do have problems like dry eye or post-op residual error, and Nidhi has already elaborated how to manage them. So treat dry eye well. If there are any residual issues, do offer PRK. And I don't have any experience of exchanging them. Most of the patients will have.
Yes, Sean?
It's not about the lens, but after counseling, after doing everything, I still remember I operated one of the lawyer and I put EDOF. And you can know, how, and the same lawyer got some refractive error. And he had searched all the Google, and I have to explain him, see, whatever it, because after every counseling, I just write one thing. Whatever we did best, but you may need to have little bit refraction. So that little bit, a last line save me, and that lawyer is satisfied because I operated another eye. So this is my experience.
Thank you, Sean. Yeah, Dr. Chetan. Mix and match. Yes, I think that's a very good option to consider. Though I personally have not mixed and matched of any of my patients so far. So one problem which I feel with mix and match is if they start comparing the two eyes. So you have to, I think, pre-op counseling, and of course you are saying that he is not happy with the eye. Yeah, second eye. Yeah. Yes. Yes. Yes, perfect, ma'am. So one of the optical I will just finish this. And So one of the optical principles, though we talk a lot about mini monovision, okay. So if you see one eye individually when you do the mini monovision, the eye where you have targeted say minus 0.5 or minus 0.75 actually does quite bad with the visual acuity if you see subjectively as well as objectively, okay. So I think from the optical point of view, it is best to target emetropia in both the eyes. I am talking about the contrast and clarity of image point of view. So if you have both eyes emetropia, patient might need near ad, but the vision will be quite crisp. If we do mini monovision, I agree that patient is better off because he doesn't have to, wear the specs for near things. But if depending on the demand of the patient, if patient really wants very crisp near vision, again in those patients also, we may have to give finally some near addition. That's what my experience is with the patients who are demanding about the near vision task. Of course, for all other routine purposes, I think, as Madam rightly said, that patient may not require any glasses. Nitin.
Yeah, what madam is saying, there are a lot of published literature on that. In my experience, Triumph Physial lens is a hybrid multifocal and EDOF hybrid, and it is classified as type 4 lens. I routinely combine Triumph in one eye and Physial trifocal in other, and gives excellent near intermediate distance vision. So, and I do it routinely. So what madam is saying is absolutely right. Even there are a lot of published papers on one eye BVT, other eye panoptics.
Thank you. So we'll move on to the next panel discussion, which are case-based. So I think we would also like you all to join in the discussion if you have any points or any suggestions to do. Just before we start with the panel discussion, certain basics, you can start the presentation. Certain basics about after using the EDOF, I think one of the most common problems, in fact, about the unsatisfied patients is the residual refractive error which is there. So, we have to think whether the autorefractometer readings, whether they change as compared to what we see in monofocals, are they reliable, and any tips for subjective refraction. So, I just want to share these 3 patients. You can see the uncorrected vision of all these 3 patients is 6/6, and with very good intermediate as well as fairly good near vision. So the first patient is EDOF, second is a trifocal, and third patient is again another EDOF. But if you see the autorefractometer readings, all 3 are showing different readings. So first, we agree that it's near emetropia on autoref as well. But if you see the third patient is 6/6 for the distance, but autorefractometer is showing minus 1.5 and minus 0.75 cylinder. So that is one of the most problems when we start any new IOL in your practice, and we definitely as ophthalmologists we rely on autorefractometer readings when the patient comes back to you for the post-operative checkup. If patient is 6/6, okay, unaided, then we are not worried whatever the autoref reading is. But if patient has say 6/9 or 6/9 parts, and now you want to do the refraction of the patient, and now generally because we are so used to now the autoref, we start with the autoref findings, right? But that is something which is problematic. So I want to ask general question to you. I will give you a scenario. So there is a patient who comes back to me. Patient has say 6/9 vision, okay? And you do a subjective refraction, the good old style subjective refraction. And now the patient is reading 6/6 with plus say 0.75 cylinder at say 90 degrees. And patient also reads 6/6 by minus 0.75 cylinder at 180. Okay? You got the scenario? So patient reads 6/6 with either plus 0.75 cylinder at 90 or minus 1.75 cylinder at 180. So which is the refraction that you want to give to the patient? Any of you can answer. Yes. Yeah, so with, okay, you mean to say, the problem with EDOF with duochrome test is there are multiple elements, focusing. So patient may be seeing with duochrome also, both are equal with plus 0.75 as well as minus 0.75, because he is seeing through different, region of the lens. Yes, anyone? Nitin?
it's a tough.
Tough question, okay.
So minus, yeah.
Okay, so I will just elaborate because the answer is exactly opposite. We have to give plus 0.75. The reason is that when you give minus, okay, you are reducing the range of vision for the patient, right? So patient, when he is accepting plus 0.75 as well as minus 0.75, when we give plus 0.75, he uses the distance element in the lens for looking at the distance, correct? When you give minus 0.75, he is using either intermediate or near zone for distance correction, right? So if you give plus 0.75, patient will enjoy the full range which the IOL is providing. Suppose as he has used say, Lucidis and plus 3 addition is there, he will use, he will have with plus 0.75, he will have plus 3 addition inside the IOL which he is using. But if you give minus 0.75, that near addition is going to reduce and patient may require presbyopic glasses. So you may have to give near addition. Okay, so that is the most common mistake. So think of whenever you are using EDOF or even trifocal, think of that patient as a phakic 20-year-old patient. Okay, so when you have a 20-year-old patient, you do fogging. So you give maximum plus which the patient can accept, okay, or minimum minus, whatever, because we want to use, have the full range of accommodation in use. Okay, so good, that was a trick question, I think it was. Next, another thing, this is one of my patient post-operatively, and I think we never emphasize on the mesopic or scotopic pupil size because most of the, our patients do fairly well with the pupil sizes. But this was an interesting patient post-operatively, and he complained that my distance vision is not clear. And I dilated the patient and checked, okay. With dilatation, he was fine, but whenever he was undilated, he was having 6.6 with minus 2. The moment I dilate, he was 6.6 with minus 0.5. Okay, so why this was happening? Anyone? Yes. So, as ma'am rightly and I had shown in the graphic also, when patients post-operatively have very small pupil, and we do get occasionally these kind of patients when you do more and more these patients. So in these cases, what happens, like I explained in my first talk that I divide the lenses in a different manner. So when we are using a center near type of EDOF, which is Lucidis, where the central element is mainly used for near or intermediate vision, when you have very small pupil, remember the most of the light is being used for near. So when you have that, then patient will require myopic correction for distance when the pupil is not dilated. The moment we dilate, the peripheral elements come into picture, and now because the zone is larger, patient can now see much better without any glasses. Okay, so I think the pupil size is really important about the using even EDOFs. The third thing I would like to emphasize on the angle alpha, which Amit already emphasized on. In monofocals, this angle alpha doesn't matter at all because irrespective of where the light rays are going or where the center of the optic, you have more often a spherical or aspheric optic, it is not going to change the quality of vision. But whenever you have EDOF with these kind of elements, okay, the central elements or the rings, even the VVT, which has a central distance, it has a ring around it. If you have a decentered IOL, patient is not going to be happy because then the visual axis falls on one of these refractive elements and patient is going to see more of this dysphotopsia. So remember that even with EDOFs, you are going to have few patients which are unhappy. So you might, listen to few of us saying that all my patients are good and they are doing perfectly fine. Yes, few patients will still have dysphotopsia and longer neuroadaptation, which is required. So remember, EDOF doesn't mean that you will have 0 patient complaints. Yes, the patient's complaints are reduced significantly as compared to the trifocal. Now we come to the interesting point where we all are going to decide for these patients which type of, so we have 3 choices: monofocal, EDOF and trifocal. So I will be of course starting with the panelists, but any of you differ from them, we'll go ahead and ask you which one you will choose. So we start with the case 1, 60-year-old lady, very typical Indian patient, both eyes are having cataract. Now if you see these 5 categories which I have created in the cases, this is very important. for the thought processes when you are deciding about the IELTS, okay? So I will just elaborate on the things which I have mentioned. The first, I have mentioned fellow eye. So when we see a patient with cataract, we also have to see whether what the other eye is doing, whether it has cataract, it has error, so we'll go on seeing more cases. The second thing is about biometry, where I'm focusing more on the astigmatism part. Occupation, because that's where, you know, the working distance is decided. Hobbies, because that's where you are going to decide what is the most amount of time patient is spending on, and ocular problem. So, Sean, I will start with you. You have the case in front. So, which one will you choose for this patient?
Yeah, actually such type of cases we got always. So if financially sound, then I will go for multifocal or trifocal. Otherwise, if financial not sound, I will directly go for monofocal.
So, no EDOF in this case. This
No
is a
EDOF,
good
sir,
case
because
for
she's
trifocal.
a lady. She don't need reading and all. She's
Okay,
just a
Nitin, I
housewife.
think you agree.
Yeah,
Is
but
that
the
right?
only thing is her in hobbies there is minimal reading. You know, she's just doing housework and TV. So I won't mind doing a EDOF because it will give her a good contrast and she
Okay,
will be,
so you are thinking of dim lit house or something like that?
yeah. So
Okay,
I mean,
maybe.
and she doesn't read much, so she's doing housework. For
Yes.
that intermediate is good enough correction,
Okay,
and she's watching TV. And
yes. Nidhi, anything else? Okay, so I will also go for trifocal in this patient. Second is 65-year-old lady, fellow eye normal, patient is emmetropic in the other eye, minimal astigmatism, again housewife. So most of the things are same except that the fellow eye is emmetropic. Sean, patient is very, very wealthy.
Yes, I will go for trifocal again. You know, even EDOF will work because she's quite young. She can.
She is also a local politician.
Yeah, then go for EDOF.
EDOF.
So that but both are the choices. If she's ready
So
to
if
pay.
politician, then EDOF or trifocal?
If politician, then EDOF.
Okay, good.
the challenge I see here is other eye is emmetrope.
Emmetropia.
So neuroadaptation is going to be an issue if you do trifocal in one eye. I would prefer to do a EDOF or a monofocal in the other.
Nidhi, you would like to counsel this patient more on few things?
Trifocal could work in these cases if you, even if the vision is 6/6, we can counsel if there is early cataract for the other eye.
Yeah. And you have to tell the patient he doesn't have to do all the time. Okay? Otherwise, these are bad patients. Next, again, similar thing, 6-year-old man, other eye has early cataract, +1, 6/9. Estimate is minimal. His occupation is farmer. Minimal reading, driving, very occasionally drives at night. No ocular problem. So, Sean, you get a lot of these patients from farms.
Choice is EDOF only, but I don't know which farmer is going to pay that much. But EDOF is the choice, and another thing is that minimal astigmatism is there that can be taken care of.
Yeah, astigmatism.
Yeah.
So, Nitin,
I would talk to the patient, counsel, give him all the three options because
Yes,
he is
perfect.
good for.
I think these farm workers, they want to be free of glasses. In fact, more of these people who are working in agricultural field, and +1 here in the other eye is an advantage because patient has poor distance as well as near vision. I think I will go for a trifocal straight away. The next case is 65-year-old, other eye has cataract 6/12. He has 0.75 diopter astigmatism, just 0.75 against the rule astigmatism. Teacher by profession, reading, also drives at night. Lot of things. Nitin, you can answer this. Can you just sit little in front so voice is audible?
See, even 0.75 I will not like to ignore. I mean, I put every 0.75 in a toric calculator. If it is toric, I do a toric.
Yes.
There are limited options of EDOF torics. I don't mind doing EDOF toric for this patient because he loves driving at night.
Yes, perfect. I think the take-home message is, even if there is little amount of against the rule astigmatism, you put it on Barrett calculator and use toric EDOFs whenever possible. Don't rely on anything else. Remember, as I was mentioning in my first talk, emmetropia gives you crisp vision. Okay, anything less than emmetropia, there will be loss of contrast sensitivity there. We'll move on to the next. 50-year-old lady, this time a HR manager, other eye has PSC, 0.75 with the rule astigmatism, has dry eyes, rest of the things are normal. Reading and mobile use is the most common hobby. HR managers are, in any organization are the most hated people, but they are the people who want to be in, control of most of the things. So, Nitin, any particular this thing?
She has a dry eye, so fixing
She has dry
is
eye.
very important.
Yes.
Then her task is going to be distance, intermediate, near, all at the same time. As I have mentioned, I'd like to combine a hybrid with a trifocal.
Okay.
She is the right candidate for that.
So trifocal for you, I think bilateral cataract, and with the rule is 0.75. You would like to change the incision anyway?
No, I don't change my incision.
So you'll still take a,
I'll put it in the calculator, and if
Okay.
it is showing toric, I'll go for a toric.
okay.
Arcuate.
Yeah. Yeah. So I think as Chitra madam said, every patient you put on Barrett toric calculator and say as the calculator says. Yes,
We
Nitin.
did a study, madam, on femto-LRIs, and it works really well with the rule. If it is against the rule, then femto-LRIs don't work as well. So as you have rightly pointed out, since it's with the rule, femto-LRIs are going to work really well.
Yeah. So now the same patient, but the other eye is emetrope. We get this patient quite frequent nowadays, 40s, 50s. One eye is emetrope, one eye has cataract. Now the same thing, she has a lot of hobbies, reading, trekking, so outdoor activities are there, software engineer by profession. So what will be your choice in this particular case?
Could you come again, sir?
So software engineer, other eye is uncorrected 6/6, no cataract. Okay, and software, reading, trekking, mobile use, kind of outgoing person, lot of activities involved, and of course dry eye which comes quite, often with software engineers. So which IOL you will use?
Software engineers are very demanding. They are like, they want everything perfect. However, it's one eye, so I am little concerned about neuroadaptation. I have done it in the past and burned my fingers. So I will go for EDOF now, because I have done it and patient, although was 6, 6 and 6, was not happy because other eye was
Emetrope, yes,
yeah,
yes.
So I mean, so I avoid such situations.
Can you give mic to madam? Yeah. So that is one more option. What I would
She's a
personally
driver
do,
also, ma'am. She can drive the car. But
so seen as a glasses. I think that's the right perspective there.
I have found this problem with Americans, Indian Americans who come here for surgery. You do a trifocal, they go back and they complain that driving is a problem.
Yeah, that is
because
true.
this thing happened.
I might, think in terms of a EDOF with higher near addition in this particular case, like say Lucidis or, which has a refractive element. Yes.
Yeah.
Yes. Minivel and Lucidis, they have higher additions.
Proxa and Minivel.
Yeah. So I will just skip through. Now this is another common, 18-year-old traumatic cataract. We'll say that zonules are all right, everything is okay. Pupil is, traumatic midrias is there. Patients now these are the young patients, they will spend, their parents are ready to spend anything to get the perfect vision for their, son or daughter. So what will be your choice? Nidhi?
Toric EDOF.
Toric EDOF. Patient unilateral cataract, other is 6/6, Nitin. So it's a similar thing which as compared to, but here the patient is very young. That's the difference. And we see a lot of these patients who are ready to spend. So for them, they say that you choose the best for my child.
Again, traumatic midriasis is another
Yeah,
issue.
correct. So when you look at, the picture, you have to look for traumatic midriasis, and many times it is missed. If you have a traumatic midriasis, no matter which aisle you put, patient will have a lot of issues, contrast is lost. So if you are planning a EDOF, do it with a pupilloplasty. Don't do it without, managing the pupil. So that's the take-home message from here. I have also few patients with home steady pupil. Sometimes we miss these findings in the OPD. So it's very important that we see the pupil size when you are doing biometry. So if you have biometry which picks up the sizes, I think that will be great. This is another common scenario, 35-year-old Fuchs heterochromic iridocyclid, other eye 6/6 because they are typically unilateral. Again, a young, outgoing guy in marketing, reading, mobile, night driving. So there are few KPs as we expect and few floaters. Again, these are the patients we commonly get. They are, in profession, they don't have problem with money, and so he wants the best. Nitin?
I will still counsel him for a monofocal. I don't want to do any fancy lens because his uveitis is young guy. We don't know what's coming. So monofocal, preferably heparin coated.
Yes. Yes. So one option is enhanced, like I said in my talk, that if you have addition less than 1 diopter in the IOL, usually MTF function is still good, and patient will not feel the loss of contrast. Remember, anything in the vitreous, patient loses contrast. Okay, it's not just about the corneal fuchs. With fuchs iridocyclid, you also have floaters, lot of floaters, and these patients have significantly reduced contrast. So I generally avoid any lens which reduces the contrast. Now, this is another thing. Both has significant cataract, housewife, mobile use, housework, but has moderate glaucoma. So, Nitin, this is also your field.
As I presented in the study, 6% cases had glaucoma. So mild to moderate glaucomas, we can choose EDOF.
EDOF.
But advanced glaucomas, only monofocals.
Okay. Sure. So my, I always feel with glaucoma or any retinal disease, for example, age-related macular degeneration, there is always loss of contrast. So myself, I will always choose either a enhanced monofocal to keep the contrast intact, or if at all patient is quite, want little bit of glass-free vision, I will go for a low near-ad EDOF, like lentis comfort or something like that, because invariably as patient is going to progress, well, there will be some loss of, fields, and patient, I have seen 60-year-old, so she is going to, live for another 20 years. So we just have one case I will just discuss before we finish. So this is a retired, I think, which I already discussed with early RMD. I think this is one of my common observations. We miss this early RMD patients. So when we see this kind of changes, drusen or pigmentary changes on the retina, the patients already have lost a lot of contrast sensitivity, which we don't pick up. We feel it's because of cataract. But till the visual changes of ARMD come, already the contrast has been lost. So these are the patients who always have problems with neuroadaptation, and they'll still keep on complaining that the vision is not clear post-operatively. So if you find any ARMD patient, just avoid any of these contrast-reducing lenses. This is common for all. A general surgeon who still operates, so he's a general surgeon, he wants to get rid of, because these are the patients who come very early, cataract is just early, 6/6 part, the main problem is the contrast is lost. So Nitin, and he's a pre-diabetic. So
I don't mind doing that hybrid trifocal and a trifocal because he's demanding work and a need for a continuous near vision. I think this combination of a hybrid with a trifocal is really working well for me.
Anything about 50-year-old who is pre-diabetic?
Pre-diabetic,
so
that also has to
a
consider.
50-year-old pre-diabetic doesn't mean much because he may control it well. He
Control
is
it
conscious, he's a surgeon, so I don't think the chances of him going for a proliferative retinopathy are low.
Do you look at the specialty of the surgeon, like he's a gynecologist, he's a laparoscopic surgeon, he's a ophthalmologist, like he uses microscope or does a general surgery?
If you see a laparoscopic surgeon, he's seeing here screen,
Yes.
he's looking intermediate at the instrument, so I think he needs everything. I think a surgeon needs full range of vision.
Yes.
And occasional driving, which obviously, how much are we going to drive at night? I think trifocals and the newer hybrid trifocals are going to do really well in this.
Yes. So I think we have to discuss all these points because many times the general surgeon, they use these retractors, which sometimes, gives lot of glares back. So these are the patients you have to, emphasize that there will be some issues with this, and whether he wants to focus on the profession where he can still use glasses and have crisper vision, or he wants to, have something in between. Lawyer, okay, other eye cataract, lot of reading, doesn't drive at night at all. Yes, Sean?
EDOF for me.
EDOF. Now
Trifocal, but this time
he is a lawyer.
I will prefer
He is a
EDOF.
lawyer who specializes
With good
in
counseling.
he specializes in medico-legal issues.
Yeah, that's why with good counseling, writing, last line I will write, you may need little bit correction. That has
Okay.
to be there.
So I had a similar patient, I counseled him for anything, and he said, doctor, if you have medical legal cases, I am, specialized in that. So I said, we'll go for EDOF. Okay. So another 50-year-old man, high myopia, okay, very high myopia, best corrected vision is 6/9. Marketing is his job. He wants to get rid of glasses. Little bit of nuclear sclerosis already set in, so you want to do, correction. Yes? Nitin?
If there is no retinal pathology like
No retinal, he's-
myeloma or something, then trifocals work really well
Okay.
because they are used to good near
Shown?
vision.
Same, sir.
Yes, Chitra madam. Yeah.
Yes, madam.
Yes. One more thing about with these high myopes, never go for, if you want to give a very good near, vision, never go for any EDOFs which have low ads. Okay? Because optically, if you see their lens power is also less. For example, they may get 10 diopter IL power or something like that. And optically, their effective near addition is always less. Okay? As far as the physics goes. So patient who has got 30 diopter, suppose IOL with VVT, will have effective higher near addition as compared to a 10 diopter IL, same IL, VVT. Okay? So that's in physics. So that's why many high myopes, which are, we put lower ad, these EDOFs, they don't like the near vision at all. So always for myopes where the IL power is less, go for the higher addition, even these trifocals. I find trifocal results are much better in these high myopes. And they are more accepting for a lot of, glares and halos as well, because the happiness of getting rid of these very high myopic glasses is very much. Yes.
Madam, if the post-refractive patient has a EKR like a Burj Khalif, would you want to also think of a trifocal? Because if EKR value is a tall EKR thing, then probably if it is a short building with a spread out, maybe you can avoid trifocal. But if it is a single tall peak, maybe we can consider it, isn't it?
So I think basically, Nitin, what happens is that the physics will tell the same thing. That there is already operated LASIK, you are further reducing the contrast.
Yeah.
Okay. The difference is because of the patient's, biology. Some patients are more accepting, they have higher retinal sensitivity and they will do fairly well. But some patients, they may not be very happy. So I think whenever doubt, go for a lens which has better contrast sensitivity. That's the, I think. Okay, so thank you so much. I think we are at the end of the session. Thank you so much for attending, and thank you all my co-panelists. Thank you.